Welcome to another edition of Our City. A few things going around the city of Elizabeth this week. On Sunday, August 3rd at 1 o'clock, I'm going to attend the Colombian Parade, which is hosted by Colombianos Sin Fronteras. This event will begin in front of City Hall and conclude at the intersection of Morris Avenue and Orchard Street. And we invite all our citizens to come out and enjoy Colombian culture on this Sunday. It also was the subject of last week's show. I look forward to seeing you at the parade. If you need more information concerning this event or any other event, please call our Public Information Office at 820-4124. And this week's show is the chairman of the emergency medicine at Trinitas Regional Medical Center, Dr. John D'Angelo, who's received his degree from Philadelphia College of Orthopedic Medicine, chief resident at Beth Israel in Manhattan, part of the Mount Sinai Health System, and Dr. D'Angelo has spent 14 years of experience in emergency medicine, and he's been with Trinitas since 2012. Doctor, welcome to the show.
Good to be here. Thanks for having me.
You know, I've chatted with you in the past and have enjoyed the conversations. Also, we've talked about people you've helped in the past as well.
That's right.
So tell our viewers a little bit about yourself that you were sharing with me before the show started.
So I grew up in Philadelphia, and my wife is from Bay Ridge, and trained in Philadelphia for medical school, then went to Manhattan for residency. After residency in Manhattan, I spent 6 years in Florida and spent some leadership as assistant medical director in North Miami. Came back to really be with family about 2.5, 3 years ago. It's good to be back.
How's a guy from Philly meet a girl from Bay Ridge? On the Jersey Turnpike?
No, not the Jersey Turnpike. We met in college, actually. Went to Muhlenberg College in Allentown, Pennsylvania.
Okay.
So that's where the...
maybe you were at a rest stop or something.
No,
the Jersey Turnpike.
No, that's not right.
So Trinitas Emergency Room, we were talking about it in the before the show. It's nonstop.
It's nonstop. Our volume is the highest in Union County, if not the highest, the busiest ER in Union County. And really, we were talking about it earlier, is it's similar to the beating heart in the sense that most businesses have downtime. We don't have the luxury of downtime. So we're 24/7, 365. We do it pretty well.
And you deal with everything, right? I mean,
everything.
You deal with from the crocodile tears to the,
that's right.
the broken bones or the serious heart attack.
Sure. We deal with anything from autism, substance abuse, to trauma patients, the full gamut.
Now, have you seen a change in the number of emergency visits this year compared to last year?
In a typical emergency room, you turn over each bed around 1,600 times, and our emergency rooms...
Is that a year?
That's right. Our year, we do around 2,600 to 2,700. We have 27 beds, and we turn them over 2,000, 2,500 times a year. So our capstone year was 73,000, and the place is built for around 35 to 40,000. So we do a great job. We're really kind of hunkered down on process.
And sometimes nobody wants to go to an emergency room.
Nobody.
Let's face it. Nobody.
No, that's right.
There's nobody that says, hey,
Sure.
I can't wait to go to the emergency room today.
Right.
Those people don't exist. So you're dealing with, besides the people who are extremely ill, you're dealing with a frustrated group that come there to begin with.
Sure, we are. We're dealing with patients that may not have access to care. And for many patients, the vulnerable group of patients that we take care of, we are their only access point. We're kind of the epicenter for healthcare for them. So there are times where they may get frustrated because they may not have been able to get into their primary care doctor, their surgeon, their ear, nose, and throat. And so they come to us looking for help, and we're there.
So how does Trinitas handle the increased volume of emergencies? You're only capable of 35,000. You're doubling that number.
Yeah.
You know, sometimes people might not have a bed. What do you do?
With 27 Department of Health beds, it's commonplace for us to use the space that we have. So I will tell you this, but we had a closet, and we ended up gutting the closet, and that's now 6 treatment areas. But that makes a substantial difference, and our patients are grateful for the care that they receive. Maybe myself, my wife might not want to be in a chair, but there are times, Mondays, Tuesdays, when the volume outstrips our capacity. So we've struggled. But really our CEO said, John, listen, this is what we've got. And we've got to think about better processes. That's our focus right now, is that how do we move our patients like Grand Central Station, how do we get them on the right track to where they need to be? So that's our focus on process.
From a doctor's standpoint of view and from an organizing standpoint of view, you've done emergency medicine not only here. This is a challenge.
This is a challenge, but it's a good challenge in a sense that our patients are now have a different sense of who we are. When I first got there, the arrival to first medical contact time was around 80, 85 minutes. The median time right now is between 11 and 17 minutes, between the time that you arrive in the emergency room and the time that you're in front of a provider. So if you can get to those patients, identify waste in the steps, and my father would say, John, you medical people really don't have it together. You know, how many times do I have to?
Wrong, your father.
He's not wrong.
No,
He'd say,
your
how
father's
many,
right. Yeah.
how many times do I have to tell my history and physical? How many providers do I have to talk to in order for them to really get to know me? I'm here to see you. You're the doctor. And so we've looked at all of those steps, maybe a list of 10 steps before you got in front of a physician, and we said, we can do it in two steps. So you walk in, you see a greeter PCA, and this is what's important for the community to understand right now, is that, you know, the experience that you received in the Trinitas emergency room 10 years ago is going to be much different compared to the experience you have today. So you'll come in right now and you'll be seen by a PCA, a patient care assistant. They'll ask you for your name and date of birth, and then they'll directly to a treatment area. We don't all have beds for everybody sometimes. Directly to a treatment area. And oftentimes the next person, or second or third, may be that doctor right away. That's a big difference. And it makes a big difference in outcomes. We'll probably talk a little bit about it later.
Well, you just raised a good point that your father raised, because it's probably the frustration of everybody. You walk in there and they ask you, well, what are you allergic to? And you say penicillin, peanuts, or whatever it is. And then somebody else comes in and says,
same
what
thing.
are you
What are you
allergic
allergic
to?
to? I just told you.
Then it, you know, so you go through this 3, 4, 5 times, and then by then the patient is probably more patient, but the family members are like, geez, when are they going to give him or her a shot or do an X-ray or whatever?
Right. And I think a lot of the frustration is communication, is perception, and that's what I'm talking about, process right now, and communication, is that if you know what, John, it's going to take you, if you're my patient, I'll say to you, it may take us 45 minutes to get some blood work done, and it may take us 2.5 hours to get that CAT scan from the time that you start drinking contrast to the time that it's complete. And those little steps make a big difference. If we can set up the expectations and let you know, and maybe introduce ourselves to whoever's around, their loved one, say, listen, why don't you go have a cup of coffee, go have lunch, and your family member's going to be here for around 2 hours, 3 hours.
Years ago, when I was the mayor, 3 or 4 years,
right.
As you say, emergency room visits have changed. Right. I broke my arm. I went to the emergency room, and I sat in the emergency room for about an hour. This was not Trinitas. This was when the hospitals were separated.
Sure.
I sat in the emergency room about an hour. Didn't even get an X-ray.
Yeah.
Now, it was clear my arm was broke because my fingers were towards my elbow.
Right.
So even I could figure that out.
Right.
So the frustrating point to me is, what does it take to get an X-ray?
Yeah, and that's goes back to the first question about steps. You've got to time each transition of care and hold people accountable to. So we know exactly how long it takes from arrival time to PCA time, meaning the first point of contact, from PCA time to the time the nurse gets there. From the time that you arrive, it takes registration. Behind the scenes, not everyone knows how much it takes for us actually to generate a wristband, to communicate to the radiology that Mr. Bolwich needs an X-ray. There's time. It takes a significant amount of time, but if you don't look at those time stamps, then you don't know where you are. We have to measure, and then we can move, and that's what we're doing now. We're measuring each one of those. So it may have taken you 15 minutes to get registered, and that goes into staffing. You got to move pieces around so that you can get efficient care.
They should have got me in for
That's right. They should have got you right away. In fact, you should have called and you get the back door.
Just kidding. So what happens when a person calls 911 in today's world?
So this is something that's very important. And I think that one of the pieces that I wanted to talk about today are twofold. And if I had to do public health outreach, I would talk about, or I'm talking about right now, that time is brain and time is heart. The time is brain and the time is heart. If I could say to the community, one thing, it would be that if you are experiencing chest pain, if you are experiencing chest heaviness, tightness, that it isn't time, we don't really have the time for you to wait for your family member to come home, maybe the kids to come home from school. What we'd like you to do is to call 911. You say, well, why would you call 911? And this is it's a critical piece right now, is because when we call 911, paramedics show up at your house and you get a 12-lead EKG. That 12-lead EKG, you talk about technology, then gets transmitted to our emergency department, where the physician on the other end can click a button and you can look at the EKG. And we can tell right there whether you're having a heart attack or not, whether your artery is closed or open, based on that EKG. Very, very important. And there are certain timestamps. The first medical contact until the time that they get to the emergency room, and then the emergency room, the so-called door in, door out time, has 30 minutes, and then the cath lab team. See, we used to downstream wait for the patient to arrive because we didn't have the technology when we called 911 to know you were having a heart attack. The paramedics now activate at Trinitas Medcom to tell the interventionalist at home, who may be 20 minutes away and sleeping in the middle of the night or off hours, that we've got someone who's having a heart attack. That will save thousands of myocytes or muscles in the heart in this case. And the same is true with stroke care as well. So all those pieces are very, very important. But the most important thing that the community should know is that calling 911 is an important step. If you wait 2, 3, 4 hours, that muscle, that pump of the heart, then has certain damage. And you're going to struggle walking up the steps. You may get lower extremity edema. These are important things. But the community should know that, you know what, I'm having chest pressure. It's going to my jaw. I'm breaking out into a sweat. These are alarming signs and symptoms that you shouldn't wait. You should get us involved early, and that's what 911 does. It connects us upstream so that we can get you on the right track to that interventional cardiologist.
So why do people wait? It's probably a good question. Maybe a doctor doesn't have that answer.
I think that's a complex question. I think that if going back to my mother or my father or my relative, they may say, you know what, I want to finish my shift at the restaurant. They may say, let me just get through this lesson plan that I have when I'm teaching a student. They may say, grandparents may be waiting for someone to come home from school. I mean, these are legitimate reasons why patients, and they may not know, they may not recognize the signs and symptoms of a heart attack. And the other complexity of it, we often have patients that may be uninsured or underinsured. And so the financial ramifications, that's what we call a synaptic event, where they may say, if I go there, maybe I'm going to have a bill, and maybe I'm going to have, and those are other pieces that they have to kind of weigh in their mind.
That medicine they can give you within an hour of a stroke, does that really work? I mean,
so stroke care. So the thing we talk about stroke care, we said time is heart, and we also said time is brain. We have about 4.5 hours. So the same is true. So if you have facial weakness, if you have slurred speech, and the T, face, arm, slurred speech, and time, we have about 4.5 hours that we know the evidence is good that we can give you a clot buster. So if you have a blockage in the heart, it's the same principle. You could have a blockage in one of the vessels in your brain, and we've got about 4.5 hours from the time of onset that you're having symptoms. New slurred speech, weakness in my arm, I'm having trouble with my language. This is very, very important for the community to understand, really is.
And sometimes getting that word out is difficult.
It is. And I always think that maybe getting to the kids is the way to go. Maybe we should do some outreach to the kids and let them know how to recognize these symptoms in mom and dad.
We're going to run some commercials and come back and talk for a few more minutes if
Great.
we can. Please stay with us after these messages. We'll be back with more with Dr. John D'Angelo. In this city, where I'm pleased to be joined by Dr. John D'Angelo, who's the chairman of the Trinitas Emergency Department. Doctor, one of the things we were talking about before the break was 911. So the connection between the response team and the emergency department, is it more than just the EKG, or is it actual dialogue, conversation? How much more intense can that contact be?
It's all of the above, really. When it comes to stroke care, we have pre-hospital notifications. So if someone is a trauma patient, they'll tell the doctor their narrative, exactly what happened in the pre-hospital setting, what kind of treatment was done, and what they need to prepare for in anticipation when the patient arrives. That's what we call the pre-resuscitation. What do I need to do to take care of the individual coming in? For stroke care, we also activate the radiology department to let them know if someone is on the table right now, that the patient that's coming through the door is going to take priority. So that connection and dialogue, along with technology, is all pieces of the puzzle.
So, doctor, you've been in emergency medicine your whole career, correct?
Sure, yes.
So, I always teach my daughter that there used to be things called payphones.
Yeah.
We don't see them anymore. Your kids are never going to know what a payphone is.
That's right, yep.
So what have you seen change in emergency medicine over your time, over the last 15, 20 years?
Technology has helped us on a couple of fronts. We have something called Relay Health at Trinitas, which ties us into over 18 other healthcare institutions throughout New Jersey, and hopefully someday it ties in all of New Jersey, and that'll help us understand who the patient is, us meaning the providers, the nurses, the doctors. We could have a possible hyperlink in the computer to say, oh, this patient was seen at a different facility, and this is what they've done. It also links us.
Is that part of the Healthcare Act too?
Is it part of the Healthcare Act? I believe it is as well, but it's the health information exchange in order to kind of move down utilization and help bring value to healthcare delivery.
And how do you, is that implemented? Not yet though, right?
Right now, Trinitas is recognized as a leader in technology, information technology. Judy Camino is excellent. I believe she's on the president or the board of the Relay Health Exchange right now. So right now, we can go in. It's been about 6 months to almost a year. Go in and see what other diagnostic testing you've had done at other facilities right now.
So you said you came from Florida. If you were traveling to Florida and took ill, would a Florida hospital?
You know, it's a good question. I wish I could tell you that we're connected yet, but that interconnectedness hasn't happened yet right now.
Is that a game plan for future medicine?
It is. It is a game plan to tie us all together, because oftentimes critical information across state, county lines aren't shared. And so if that information was there, we argue, the medical community, that the outcomes will be better. And I think that that's part of the next generation.
So we were talking about outcomes in the first segment, and you said we get into it more. How do you measure outcomes in your business?
Yeah.
Do you measure outcomes based on the number of beds you turn over? Or do you measure outcomes based on the success of the patients? How do you measure an outcome in the emergency room? Because nobody wants to be there.
Sure. I mean, I think that I would say that the most important outcome for a lot of our patients is the experience that you're going to have when you leave. Not only in the hospital, when you're to be discharged. So that service is something that we survey our patients and ask them how we're doing. You know, my father would say at the restaurant, he'd say, you know, how was the experience there? But a lot of times our
you're
patients.
a lot of fun, but I think I'm going to have your father on this show.
No, my dad was an interesting guy. But so we do a couple of things. We do heart care right now, so we know exactly how long it takes us as far as outcomes go for our patients with heart attack. And we know right now the benchmark is 90 minutes from the time that you begin having the heart attack is recognized to the time that we open up that vessel. Ours is around 68 minutes right now. Pneumonia is another outcome right now. We're 100% for pneumonia for the past 18 months. So we have certain antibiotics you're supposed to receive in a timely fashion, and we've been doing that very, very well. So those are two: pneumonia, heart care,
There's a time
brain
on
care.
pneumonia?
There's a time in pneumonia as well.
Or can overtake you?
There's something called sepsis, and I'm sure you've read
Sepsis, sure.
Sepsis and pneumonia is one of the sources of infection that can lead to sepsis, which is kind of this chaotic environment within the body where it just shuts down organs. Pneumonia is a leading cause of it, and one of the leading causes of it right now. So we have protocols right now to recognize inflammation in the body, but you can't recognize them until you get the patient in front of the provider. So I cannot stress that enough, and this is difficult for our staff, but they now appreciate it now, that getting the patient in front of the provider is going to improve outcomes. Is it going to be more difficult? Yeah, it is going to be more difficult. Are you going to feel more stress? Yeah, you are. But I can tell you right now that when the outcomes begin to improve and you can see your patient saying, this is a different experience, then that's easy to get buy-in. And we're seeing that now, which is exciting.
So is there such a thing as walking pneumonia?
I know, it's kind of misnamed. A lot of us can walk around. It sure is. I mean, if someone is ill with multiple comorbidities, like diabetes, they have high blood pressure, high cholesterol, they're not going to do as well as someone that has, you know, maybe 15 or 16 years old with pneumonia. So we all can walk with pneumonia.
Well, you always hear that term.
I know you do.
And
yeah.
it's like, so for a layperson, it's like, what the hell is that?
Yeah, that's right.
I probably shouldn't have said that on TV, but I did. So, cardiac patients, nurses, I have some notes here about lowering a patient's body temperature. What does that mean, and how is it used?
So one of the things that we do very well on wound care, stroke care, heart care, and then resuscitation care. Part of resuscitation, if you're very, very sick, and let's say that your heart were to stop, we have a protocol. It's called Code Frosty. We like to call it
Code Frosty.
Code Frosty, yeah, it sounds a little bit.
only-
That predates me, but anyway, it's hypothermia protocol. So we lower your core temperature so that it kind of quells the storm inside you to let you heal. And that's what we do. There's wraps that you put on a patient's legs, on their chest, to lower your temperature down so that your body has time to heal. and kind of fight its own infection. That's very, very important, and we do that frequently.
Is that only used in heart attack or stroke patients, or is that used in other?
It came out, the literature came out of patients that had brain injury and heart injury. So those are the two kind of nidus. That's where it came out of. Oftentimes now it's for a patient that is on a ventilator, on a breathing machine that is in coma. So that's one example. If you're on a breathing machine and in coma, typically the studies came out of, they start with one thing and say, well, let's try for something else. So it came out of those patients that had an arrhythmia, who we shocked, we brought back, and they didn't wake up. And we said, is there any way we can improve their outcome? They go home and they have a cup of coffee, or they go back to their daily living. And we said, let's try to cool them and see if we can improve outcomes.
So there's clearly an increase in emergency room patients through the years because of healthcare and lack of healthcare.
Sure.
Do what you see in emergency rooms more complicated than what you did see?
They are more complicated. I think it has to do with the generation that we're serving right now. The boomers are here now, the complexity of disease, and truthfully, patients are living longer. Patients are living longer. You're deep into your 80s now. That's not uncommon to see. And the complexity and the comorbidities, you may have a patient come in with 15 different medicines that they're on. 15 different medicines, each one of them with their own unique. I'm going to reserve that. Can I take the fifth on that one? I'm going to. Yeah. It depends. It does. I mean, my practice is emergency medicine, so for me to comment on outpatient wouldn't be fair.
Wouldn't be fair.
Wouldn't be fair.
But 15 medicines. I mean, I got to tell you, once you get past blood pressure and cholesterol, what is there else to take?
Yeah, there are sicker patients, and in particular the community that we serve because of insurance. So they may be intimidated to come present, so they're going to present later in their disease course. A young male who maybe does not have papers or undocumented right now may not come in to see us because they're fearful of the outcomes, and that's unfortunate. We see that quite a bit.
Well, I'm glad you raised that point. There's no checklist on that issue if you come for emergency care. Everyone,
and this is very important, that comes into emergency room, we are the safety net for the healthcare. United States. The emergency rooms are the safety net. I can't stress that enough. In other words, please don't be fearful to come see us because of lack of insurance. That's not, we are here for you. We are here, and everyone that comes in there, we don't ask you about your insurance. We don't deny anyone that comes in to see us. Everyone gets a medical screening examination that comes in the emergency room. It's
citizen
the law.
Or non-citizen as well.
Citizen or non-citizen. 1986 under Reagan, we passed the law, MTAL law.
Right.
So we do see you, and that
undocumented or documented.
That's right. That's right.
They have the access to emergency.
They certainly do.
So.
And it's something that we're proud of, as emergency room nurses, physicians, assistants. We're very proud of that. That we are able, we're here when you need us. We're here, 24/7.
So, your personal satisfaction.
Yeah.
Yeah. Work in the emergency room. What do you point to? What do you go home and say, hey, you had a good day?
There are, I'll tell you a story. How's that? So we had a 51-year-old female who presented when her daughter came home from school with chest pain 3 Mondays ago. And I was called to the bedside. We have a process where we get an EKG right away. So she came in, she was seeing you have chest pain, you walked right in the emergency room and you received an EKG. She was having a heart attack. She was in room 4. So I went to the bedside and her family was around her. She was diaphoretic or sweaty, had pressure. And we looked up at the monitor and she lost her rhythm. She went into this chaotic rhythm, okay, just to kind of bring all these pieces together. Mm-hmm. She lost her pulse, unconscious. Right in front of the family, the nurses knew enough. Our nurses are smart enough because they're so well trained with our school of nursing. Put her on the pads. This is them being well trained. We always say that you fall to the level of your training, okay? In stressful situations, you fall to the level of your training. So without thinking or verbalizing, what needed to get done was done. And we put pads on her, defibrillation pads like you'd see on the ER shows on television. And we took that chaotic rhythm, we gave her some joules, some electricity, if you will, and brought her back. She did it again. She did it 3 times. Now, the family was there. I'm okay with the family seeing, what had happened.
Right.
And at that point in time, we activated the code STEMI. We called the interventional radiologist, Dr. Shamoon, who's fantastic. She was upstairs, and we opened up her vessel within 17 minutes of arrival. I mean, and so that's the kind of stuff that you say, I had a bad day, but there's always someone
But in 17 minutes.
but there's always some story, someone in the room where you can say, my day was difficult, but it was a good day. You see,
I want
and
to
that's the
thank you for
difference.
taking the time to join us on the show.
Good to be here.
Thank you very much.
Thanks.
For Dr. John D'Angelo at Trinitas Emergency, I'm Chris Bolwage, and we'll see you next week on another edition of Our City.
Offering everything you could want from college, including a life. Kane University.